Good evening, everyone. This is Dr. Weaver, and I'm going to try to get this presentation together on the peripheral vascular system and also the lymphatic system. We are continuing in chapter 21. I'm going to try to, of course, go over slides 1 through 1 through 18. And because my method in the classroom is not to hurry up and get through the lecture, because when you're going too fast, then you tend to lose students. And I'm trying to do this in such a way that you guys will, be able to obtain the information, and it stays with you, of course. As you all know, health assessment is going to be very important because this is where we are able to, discover whether or not our patients are healthy or not. And so, of course, at the bedside, I mean, we're performing assessments, be that in the clinic, in the acute care setting, and a host of other settings. But for the purpose of this particular presentation, of course, most of our patients would be in the acute care setting, but you can use your assessments, these types of assessments in other settings. So keep that in mind. Um, so, all right, so without further ado, because I don't want this video to be too long. All right, now let me say this. You are going to have your textbooks, your textbook with you. What is it, Jarvis, I believe. You will have to have your textbook with you because I do make reference to various pages. So please make sure you have your textbook with you as you go through this presentation with me. All right. So let me go ahead and let's see if I can share, not share, but present slide 19 to you all. Let's see. There it is there. Right. Right. Trying to move some of this stuff out of the way. All right. All right, so we are on slide 19. As you can see, the header here is objective data. And of course, you all know by now the difference between subjective and objective. Subjective is what the patient is essentially telling you what they're feeling, right? The subjective, it comes from the patient. And objective data is what we're able to physically see with our patients. Now, keep in mind that um, the physical, you're using a lot of your senses, right? You're using that sight and smell and touch and hearing when you're doing these physical assessments. The physical examination, it requires you to develop the technical skills and knowledge base. The technical skills are the tools to gather data, right? And again, we're using our natural senses, the sight and the smell, touch and hearing, in order to gather data during the physical examination. Keep in mind, with in the health assessment class, we're not using the really high techy type of tools, such as the MRI and the CT scan, and a host of other tools. Those will be used at some point, in particular, if we discover an abnormality in our patients. All right. For example, if upon physical examination we detect that the liver is enlarged, then of course, we will get a CT scan and perhaps some other appropriate sophisticated tests, if you will, in order to further investigate. But that's why the physical assessment is so important because it enables us to catch those issues so that further investigation, will occur. And hopefully we can find what the patient's problem is. Now, the skills that are required for the physical examination, and you guys got this last term, are inspection, what you can see, palpation, what you're able to feel, percussion, which don't do a whole lot of percussion. I mean, I see some doctors do it every now and then, but don't do that a whole lot. But we're going to make sure you know how to do it anyway. And also auscultation, what you're able to hear. All right. And they are particularly performed one at a time and also in the same order. Inspection first, palpation second, percussion, and then auscultation. That is the order that we typically employ doing a physical assessment. All right. Now, as far as preparation is concerned, during a complete physical examination, we examine the arms at the very beginning, particularly when we are checking the patient's vital signs, and also the patient is in a sitting position. All right. Now, examination of the arms and legs includes peripheral vascular characteristics, and we're also looking at the musculoskeletal as well as neurological findings as well as it relates again to the arms and legs. We also want to make sure that the ambient temperature is comfortable for the patient. Typically, we like roughly about 72 degrees. Your book says 72 degrees, but to be quite frank, I don't know, that might be a little too cool for some patients. I mean, I might think about increasing the temp a bit, especially if we're talking about an elderly patient, and especially if they don't have a whole lot of subcutaneous tissue, wherein to keep them warm, if you will. All right. Now, so we want the temperature to be comfortable for our patient. You don't want the patient shivering and those kinds of things. We also want to make sure to include bilateral comparison. You just can't inspect one leg or the other, or one arm or the other. We have to make comparisons because usually our arms and legs are the same, are similar. All right, similar in size, similar in temperature, similar in shape, and so forth. So we want to compare, always make a comparison. Look at the calf of the right lower limbs, and we look at the calves and the left lower limbs, and see how they compare, contrast, if you will. As far as equipment is concerned, we need to make sure rather we have paper tape in order to measure our patients, tourniquet or blood pressure cuff, stethoscope, and also a Doppler ultrasonic stethoscope. All right. Now, we examine the legs directly after the abdominal examination, while the patient is still in the supine position. And the reason for that is, whenever you can assess a patient, when you can assess more than one system in the same position, that is always a great help for especially our elderly patients. I mean, can you imagine moving them into various positions wherein you just will exhaust them, right? If you could assess, let's say, 3 systems in one setting, if you will, then it would be a whole lot easier for these patients instead of having them get up, get down, bend over, and all these different positions, things that you can group together, right? So as not to again wear the patients out. Now, after we, of course, we examine the patient's legs in the lower limbs, if you will. We want to have the patient to then go from a supine position to a standing position to evaluate the leg veins. And again, as I said, the temperature we want to be about 72 degrees Fahrenheit or 22 degrees Celsius. And we want to also make sure that there are no drafts coming in the room, because drafts tend to cause vasodilation and also vasoconstriction, which can throw off our assessment. All right. We then use, of course, inspection initially, and then palpation in that order. And then, of course, we compare findings. Now, I mentioned here about the Doppler ultrasonic stethoscope. Um, this is a device that is used to detect a weak peripheral pulse. Sometimes the pulses in some of our patients are so weak that we are unable to palpate for a pulse. And so you need a more, it doesn't mean that the pulse is not there. It's just that for whatever reason, the patient may have a cardiac issue. And so the pulses may not be as strong. And so we need another tool to help us to determine what the pulses are, or if the pulses are present, I should say. We also use this device to monitor blood pressure in infants or children, or to measure a low blood pressure or blood pressure in the lower limbs as well. I just want to give you an idea of what that device is used for. All right. So we're continuing with inspecting and palpating the patient's arms. In your textbook, it speaks about the normal range of findings as well as abnormal findings. And so you should always know what are the normal findings. It's just like with diseases and disorders, which you'll get in MedSearch 1, 2, and complex, which is complexes with me. You always want to know what your normal is, so that when you see anything that deviates from that normal, then you know that there's a problem. All right. Now, you may not know what the problem is, but you know that there is a problem. All right. Something that you can report to the healthcare team, and don't feel bad about you not knowing exactly what it is. All right, because it may warrant, some additional labs. It may require additional imaging and what have you, in order to further investigate and reveal whatever the issue is. And so, and kind of the same thing. Well, it is the same thing. For example, with anatomy and physiology, you must know your normal, and that way, when things deviate, meaning pathophysiology, that which deviates from the norm, then we know that there's a problem or some pathological issue that needs further investigation. Right. Now we want to lift both the person's hands in our hands. We inspect and we turn, and we then turn the person's hands over. We are looking at the color of the skin. We're looking at the patient's nail beds. And also we're noting the patient's temperature, texture, and the turgor of the skin. All right, because turgor tells us whether or not a patient is dehydrated. And also the presence of any lesions, edema, or clubbing of the fingernails. All right. Remember, with clubbing, you think about those patients with COPD, these respiratory conditions, who are not getting adequate oxygenation. And so this tends to change the structure of their fingertips. All right. We also use the profile sign when viewing the finger, meaning basically we're viewing the finger from the side. And this will show us that clubbing. All right. It detects early clubbing. Now, the normal nail bed angle is roughly about 160 degrees. And let me see. I don't know. See if I can show you what clubbing would look like, and that profile sign that I mentioned. Hopefully you can still see this as I move from one thing to another. That's that paper tape there, which you all should know about that. Let's see, profile sign. Let me do it this way. I like the electronic books because you can do a search, right? And get you where you want to be rather quickly. Let's see. So the profile sign, use the profile sign. I thought there was actually a an image that I can show you what that looks like. Uh, Profile sign. That's that Doppler there that we use. All right. So let me do this. Profile sign. If that'll show me anything. Oh, wow, nothing. I think this is it. All right. So you're basically looking at the patient's hand from the sides, and then you should be able to see what it is. For example, here, this is a normal thumb here, but see if I can make that bigger. I don't know if I can. No, that's not cooperating. Well, hopefully you'll be able to see this, what I'm showing you. Maybe this one would be better. Yeah. So this is a normal finger. You're at 160 degrees, right? That's what it should look like, right? And then you have the club finger here, which the angle would be greater than 180 degrees. And it looks like a club at the tip of the fingers, right? That's the profile sign, right? Um, all right, so you get the picture. Get out of here. Right. Um, all right, let me move on from there. All right, so like I said, the normal nail bed angle is about 160 degrees, and the abnormal would be greater than 180, and it looks like it is clubbing. All right, now whenever you see the angle that is more flat, and also, of course, a clubbing, um, essentially you have this diffuse enlargement of the terminal phalanges or at the end of the fingertips, which is what we were looking at. And this can happen with congenital cyanotic heart disease or also what we call cor pulmonale. Cor pulmonale is essentially right-sided heart failure. Um, don't think they use that term a whole lot nowadays, but it is right-sided heart failure. And so, this is what clubbing can tell us. All right. Let me go back here. All right. Now, we also want to check the patient's capillary refill. We want to know if it's brisk or if it's too slow or sluggish and whatnot. We check the radial pulses and we grade the amplitude on a 3-point scale. +1 is weak, and all the way to +3, which would be a much stronger pulse. All right, as you can see here, 3+ is increased, and then a full bounding pulse. That can be abnormal, but then you have your 2+, which is normal, and this is how you would describe this information as far as your objective data. And of course, you have the very weak +1. You do feel a pulse, but it's very weak. And then some pulses are just absent. All right, they're truly not there. all right, as in some kind of peripheral vascular disease, what have you. The ulnar and brachial pulses are not typically assessed, as you can see here. There's also a test that we call the modified Allen test, which provide information about the adequacy of collateral circulation. Now, this is important for you to remember, right? And you'll especially see this in, you'll see this in complex health because there's a device we call an arterial line. It looks like an angiocath, like an IV that you insert. For example, you can insert it in the radial pulse, right? You can insert it in the radial pulse. They also sometimes insert it in the femoral pulse as well. And so what happens is this device actually helps us to note or gives us a patient's blood pressure in the arterial system. You know, you have your cuff pressure, but you also have your, your internal blood pressure, which is the arterial line. And so we're going to insert, or the physician will insert this this catheter into, let's say, the right radial artery. All right, but before that is done, you have to determine if the patient has good circulation in both the radial and ulnar artery. The reason for that is because when you insert that A-line, a catheter into the radial artery, if the ulnar artery is occluded, then you're not getting circulation to that hand. All right, and then that hand, goes through the process of ischemia and necrosis, and a patient can lose their hand. Let me show you, see if I can possibly show you what that will look like. It's called the Allen test, and it's here. So basically, what we do is we depress both the ulnar and the radial artery. This is the radial, and this is the ulnar. We compress both, or depress both, right? And then what we do, the hand will turn, eventually it'll turn white. So we do ask the persons to open and close their fist. And so then we maintain pressure on the radial artery, since that's where the catheter will be, but we will release the pressure on the ulnar artery, all right? And what should happen is blood flow should return to the hand, and it should return back to a pinkish color if it's normal. If the ulna is occluded, the hand will still remain kind of like this whitish or pale color, right? So because we still have the radial artery that is compressed, but if there's an occlusion, as you can see this little, I don't know what that is, maybe a blood clot. If that is present, then you don't want to insert an A-line in this radial artery. You may want to choose the other hand, or you may want to choose the femoral site. So that's basically the Allen test. You don't need that. You should. You could be testing on it, but you don't need to know about the A-line and what have you until you come to a complex for the most part. But you may still read it in your patient's charts. Let's say if you go to MedSearch 1 or 2, and you receive a patient, or you get report on a patient that you're caring for who has, let's say, they came from the ICU and they did have an A-line. And so you will want to know that, because that will be a part of your assessment as well. All right, so that's what that is, the modified Allen test. All right, now with the person's hand near the level of his or her heart, we want to check. So when we're checking capillary repair, we want to place the patient's hands near the level of the heart. All right, now this is an index of peripheral perfusion and cardiac output. If a patient has good capillary refill, it lets us know that the patient has adequate perfusion and the cardiac output. you know, the amount of blood the heart puts out in, what is it, in a minute. All right. The heart puts out about 4 to 8 liters of blood per minute. And so if that cardiac output is adequate, then the capillary refill can give us an idea if this is the case. Right. So we do depress and blanch the nail beds and release, and we note the time it takes for the color to return. Right. Now, usually the vessels refill within a fraction of a second. So that when you compress it, when you blanch the fingernails, it will turn white, but the color will come back fairly quickly. All right. We can consider it normal if the color returns in less than 1 to 2 seconds. Um, Now, we have to note that there are conditions that can skew your findings, that can make them abnormal. For example, a cool room. Remember, we said earlier that we want the ambient temperature in the room to be about roughly 72. But say if the temperature is about 65, well, that can cause circulation issues, and so it would skew or give us abnormal results, and that's not what we want, because that's not actually true for that patient. It can also be due to conditions that can affect capillary refill. It can be decreased body temperature. The patient is hypothermic, right? Cigarette smoking, because remember, with cigarette smoking, the chemicals cause vasoconstriction. There's also peripheral edema, all right, which can impede circulation to the extremities, as well as anemia. So think about those conditions in the context of your capillary refill assessment, because they can alter your findings. Now, if the capillary refill lasts more than 1 to 2 seconds, this signifies that there's maybe vasoconstriction or a decrease in cardiac output. The patient, for example, can be in what we call hypovolemic shock, meaning they have little volume in their vascular system, right? It can also be due to heart failure. The heart is not pumping effectively, and so you're not perfusing blood flow to your extremities, your distant extremities. There can also be shock, and with shock, the blood pressure can drop significantly, and of course, if that happens, your cardiac output drops, your perfusion drops as well. Something we call also mean arterial pressure, or MAP. If you look at a blood pressure on a machine, you'll see like the systolic over the diastolic, and in parenthesis, you will see a number, and that is the mean arterial pressure. And there's a formula that you don't really have to know, but just kind of take a look at it one of these days and get familiar with it, just in case you have some other device that only gives you the top and bottom number, but not the MAP. And what the MAP basically shows is it's called mean arterial pressure, how well we are perfusing our organs and tissues. And a normal blood pressure will determine that. The mean arterial pressure should be roughly 65 to 70. All right, that's normal. All right. Let's see. Also, the hands can be cold and clammy and pale, which again can signify a circulatory issue. All right. I can't help but kind of more or less include some of the things that you guys are going to see when you come to MedSearch 1, 2, and also Complex. And so you might see me taking a little more time with these presentations, because believe me, you want to be able to make the connection. Um, it's like when you study pharmacology by itself, and you don't study it with the disease process, diseases and disorders that you'll be studying in MedSurg 1 and 2, and also complex, it's kind of hard to make the connection, right? But if I taught a beta blocker while I was teaching you about congestive heart failure, then you'll be able to see how the drug affects the condition, if you will, and it will stick a whole lot better. But when it's done in a kind of isolation, right, or as far as proximity, distance, right, then sometimes it's just hard to grasp, why you're learning certain things. All right. So just keep that in mind. That's kind of what I'm doing here. Now, this next slide, I want you to take a look at page 510 to 518. There's a grid for your physical exam. This particular grid tells you about the normal findings, as I was telling you about, but it also points out the abnormal findings. All right. So we want to, while continuing with the our objective findings of physical assessment, we want to uncover the legs while keeping the genitalia draped. All right. Some of us are a little modest, and so make sure you're properly draping your patient. All right. All right. So we are going to inspect both legs together, and we are noting the skin color, the hair distribution, if there are any venous patterns. You're looking at the veins, in other words, the size. In other words, is the are the lower limbs are they swollen, or is there atrophy? Atrophy can occur in muscles when there's disuse. You take some patients who are on bed rest a lot, and they don't use those muscles, and so it can atrophy. All right. And any skin lesions or ulcers as well, you want to, these are all the things you're taking a look at. Pallor with vasoconstriction, you're looking at that. You're looking for erythema, and that occurs with vasodilation of the blood vessels. And also you're looking for cyanosis, which is bluish discoloration due to lack of oxygen. All right. Now, if the lower legs look asymmetric, they don't look the same, we want to measure at the widest point first, right? Measure at the widest point first. And we have to take care to measure the other leg in exactly the same place, all right? Because that would tell us whether we're dealing with asymmetric versus a symmetric measurements. Now, the same number of centimeters down from the patella or some other landmark will be important as well. That paper tape measure that I showed you earlier, this is what we're using. And we're measuring in centimeters, and this is what you're actually reporting, right? In the presence of skin discoloration, skin ulcers or gangrene, we have to document what the size and also the exact location. All right, and you have to think about those anatomical terminology, anterior, posterior, dorsal, right lower extremities, left lower extremities, and so forth. You have to make sure you are using those types of terms, because this is the language that we speak in nursing. All right, we also palpate for temperature along legs down to the feet. And again, we're looking at both. We also palpate the lower extremity pulses using, again, bilateral comparison. If one extremity is 1+ and the other one is 2+, then that warrants reporting to the healthcare team for further investigation. We also use a device called a monofilament to assess the neurological status to determine the sensory assessment. It's a sensory assessment. Can the patient feel? All right. I don't know if your textbook has the monofilament device. Let me see something. You will notice that I do refer to the textbook a lot because that's what I teach from. Let's see, monofilament. It says it's on. Oh, here it is. So for those with a history of diabetes, peripheral arterial disease, HIV, test for sensation on the sole of the foot using a monofilament as described in figure 24 on page 657, 516. So 657, see if I can pull that up. Oh no, 657. Why's that the one I want to change? All right, let me do this. No. And I don't know why this is being contrary. We'll try this. Yeah, so this is the monofilament device here. All right. And we're just basically checking the sensory, we're doing a sensory assessment. Can the patient feel? Right. And so this is one of the conditions to consider. Diabetes increases the risk of peripheral neuropathy. In other words, diabetes, those high blood glucose levels, destroys the vascular system. That's why high blood glucose levels are very dangerous. It destroys the vascular system. If the vascular system is destroyed, then you can't get blood flow to your nerves, and then nerves die. And as nerves die, they become unable to carry out their function being enabling the patient to feel. So if the patient cannot feel any one of the 10 sites, then a referral is necessary, as you can see here. So they touch these 10 sites here, right? The monofilament device. And so that's what that is. Let's see, 516. Go back. All right. Now, as far as the hair is concerned, hair covers the lower extremities generally. But even if the leg hair is shaved, you still note the hair on the dorsa of the toes, because some patients we have hair that grows on our toes, right? The dorsal aspect, not the ventral. Those are the terms, dorsal, ventral. So on the dorsal aspect, all right. And so you should see hair. Usually, when people shave their legs, they don't quite necessarily, at least I don't think, shave the dorsal aspect of their toes. Now, as far as malnutrition, think about malnutrition. This is something you would note in your assessment as well. Um, when the patient's lower limbs look thin, shiny, you have the atrophic skin, thickened, ridged nails, loss of hair. There's also ulcers or gangrene. And these are the things that you would note in patients who don't have an adequate diet. Malnutrition, pallor, and coolness occur with arterial insufficiency as well. Right. So when you see malnutrition, pallor, and coolness, think about an arterial problem versus a venous issue. All right. And so we talked about those with the history of diabetes, PAD, and HIV. It is important to test the sole of the foot using the monofilament that I showed you earlier. Now, sensory loss occurs with arterial deficit, and especially when we're talking about diabetes. And again, the reason why there's a sensory loss is because high blood glucose levels are very toxic, if you will, or very damaging to our vascular system. And remember, the vascular system is what delivers blood to our tissues and organs, right? And so, the that within that blood, of course, is oxygen and nutrients and minerals and all those important items that our tissues and organs need in order to carry out their normal function. All right. And so, when the high blood glucose levels destroys the vascular system, then we get a decrease in blood flow to our tissues and organs, and then they fail. All right. Kind of like if you think about also, well, another example, the kidneys. The kidneys, you have your two kidneys normally, and blood flow is delivered to your kidneys in order to keep those cells alive and helps the kidneys to function, right? But when people have diabetes, then the vascular system is destroyed, right? And then you're getting less blood flow to the kidneys, and then the kidneys begin to fail. And so this is why a lot of your patients end up with renal or kidney failure. All right, let me go back. Talked about that. Expect. Let's see, 518. Just want to show you. Now, of course, in terms of when you guys come to your lab, you always want to take a look at, and not all of these, but you want to take a look at, again, these grids here. This was on page 508. I have 510 for some reason, but I think you can start on I have 510 to 518, so maybe I need to change that. Let me change that to 508. All right. And so you're going to look at, you're going to inspect and palpate the arms, right? And this is all how it should look, right? And then, of course, you actually want to go from left to right. This is what it should look like, and this is the abnormal findings. Normal findings, abnormal findings. And then it gives you an idea of what it could possibly be. You know, you may not know what the issue is, right? For example, here when it talks about how to check for capillary refill, all right, it can be hypovolemia, right? Reduction of volume in the blood vessels. It can be heart failure. It can also be shock. So we don't know. It can be the fact that the room is very cold. It could be some of some bad habits that patients have, like smoking. All right. So, but you need to really know this, people, right? Because it's not for you to diagnose, right? But at least by your knowledge of what the possibilities are or what the differentials might be, like a differential diagnosis, not officially on your part, but it gives you an idea that the patient can have this, can have that, can have the other. And of course, when the physician begins to work up the patient, then they may mention some of these things and, kind of make you feel a little smart. So anyway, so take a look at all of these. Look at the different, the way we document the pulse. Check this one out. So the full bounding of 3+ occurs with hyperkinetic states such as exercise, anxiety, or fever, anemia, and hyperthyroidism. And of course, if it's weak, you have a weak pulse, so one extreme to the other, it can occur with shock, peripheral arterial disease, and so forth. And so you want to always take a look at these and get an idea of what the issues can be. That's really important, right? So just make sure you're following these pages. You see how they're comparing both left and right, upper extremities, and so forth. Now, look at your lab sheet, and it will tell you what you need to be looking at. And I say that because, for example, the modified Allen test, we talked about it. You should know it. You could be testing on it, but it might not appear on your lab sheet. I don't know at right off and whatnot because I'm just taking over this class for Dr. Mitchell. But if it's not on there, you kind of read through it, you understand what it is, but move on to and focus more so on those items that you will be that you'll have to perform in the lab. Now, as I mentioned, you still have to know what these are because this information could appear on the exams or the quizzes and whatnot. All right. So just take a look at this entire thing here, how we measure. Remember, we measure at the widest portion and then down to the narrow portion of the extremity. All right. Let's see, checking pulses and all that. So just take a look at this table, 508 to 518. Let me go back here. All right, now we're looking at palpation of the lower leg, femoral artery, and pulses. Right. Now the femoral artery, so we have to be able to locate the femoral artery, which is just below the inguinal ligament, halfway between the pubis and the anterior superior iliac spines. And we can look at some of the anatomical images and get an idea of what that looks like. So don't get caught up in these big terms. All right, this just gives you a more technical definition or description of where to locate these pulses. So, but for the most part here, we're looking at the femoral artery. We're checking the pulse thereof. Remember, arteries produce pulses, right? Pulses are not produced in the veins. They're produced in the arteries because remember the arterial system comes off of the heart, and it is where the heart pumps blood to our organs and tissues. And so again, we're looking at the femoral artery, the popliteal pulse, which is in the back of the knee, the posterior tibial, as well as the dorsalis pedis. And you may be tasked with assessing these pulses, especially if you have a patient who has, for example, some pretty severe peripheral arterial disease, let's say in one of the lower limbs, and the doc had to go in and do a femoral popliteal bypass surgery. In other words, you bypass the occlusion. And so you have to be able to go in the room and assess your patient and making sure that they still have a pulse and that they're still perfusing blood flow to that area of the body and whatnot. And then of course you have to document this. Now let's say if you go in a patient's room and after the patient has had a femoral popliteal bypass surgery, it's just a surgery to bypass the obstruction. You use a blood vessel that you attach it to or before the occlusion, and then you bypass the occlusion and attach it to the other part of the artery. And of course, this should reestablish blood flow, and hence the lower limb should be warm, have good sensation, able to move the lower limb, and you should be able to feel a pulse. All right. And so, for example, a posterior tibial and a dorsalis pedis, that's pretty common. All right, that's pretty common in the acute care setting. And sometimes you may not be able to actually palpate with your fingers the pulses and whatnot. And so we have to use like a Doppler device to do that. And I think I showed you a Doppler device. If need be, I can go back and show you what that looks like. Now, this is on page 512 to 514 as far as your physical exam demonstration. I don't know if you have to do this in the lab, but you may have to at least do the posterior tibial and the dorsalis pedis pulses. I would almost I won't bet, but I'm almost sure that you'll be at least assessing those areas. So take a look at your examples in your book and how to perform this assessment. Let's see. Like I said, don't get caught up in these different terms here. Read through it, but for the most part, by looking at your images, you pretty much know where these pulses are. All right. Now, for example, this is your femoral pulse, right? It's near the ingranal area, and you should be able to feel a pulse in that area. All right. This is your popliteal pulse, and look how this examiner positions his hand. I'm assuming that's a male. Look how he positions the hand from here to here, and then you should be able to feel a pulse, a popliteal pulse. All right. This will be your posterior tibial pulse. And again, as I said, if a patient has some kind of a bypass procedure on the lower limbs, this is what this is part of the assessment to make sure that the surgery is effective. You know that whatever that occlusion you bypass, blood is going through through that that blood vessel and supplying the lower limbs. And so when the best, I'll tell you this, we talked about capillary refill and those kinds of things in order to determine if a patient is perfusing their limbs, right? Or various parts of the body, but particularly the upper lower limbs. But the best way to determine if a patient really has a good perfusion is by detecting a pulse. Cap refill is fine, but there's too many other variables that can actually affect that, like a cold room or cigarette smoking and so forth. But a pulse is much more definitive. And so always keep that in mind. All right, so that's your posterior tibial pulse. This is your dorsalis pedis pulse. All right. Now let me tell you something about this. So sometimes, especially depending on the patient may have a history of diabetes, hypertension, high cholesterol levels, and what have you. And sometimes there's so much plaque built up within the arterial system to the point that it's really difficult to detect a pulse. So we have these markers in the hospital. They are not erasable, but you can actually wipe off the ink and whatnot. But it's for the scan. You can get one of those, and you can actually, like, let's say, mark an X here. Look at my cursor. Mark an X here, or wherever the pulse is. You mark an X right on top of it. Because what that'll do, if you're so gifted and you've been able to discover where the pulse is, help out the next team members and mark where the pulse is. And then that way, when everyone else comes after you, they're able to go directly to where that pulse is. All right. Really important to be able to do that. And also, if we need to use a Doppler instead, because you just can't palpate or feel the pulse, then you want to just go where you want to mark it with the X, and that way we can take the Doppler device and place it right in the middle of that X, where it intersects, right? and then you're able to um, assess the pulse a whole lot easier. I hope that makes sense to you. All right. Again, that's on page 512 to 514. All right. So the next topic component of this lower limb extremity assessment is pretibial edema and pitting edema scale. All right. So we have to check for pretibial edema. We want to firmly depress the skin over the tibia and also the medial malleolus for about 5 seconds, and then we release. All right. And when we release, if pitting edema is present, we grade it on this particular scale. If there is really not that much swelling, we would document that as a 1+ mild pitting, a slight indentation, but no perceptible swelling. All right. Now, in the hospital, so I know you guys went to the hospital during the fundamentals of nursing, but in the system itself, and what happens is, as far as the section where you're actually clicking and selecting different options in your drop down, it'll actually have 1+, 2+, 3+, 4+, and then you just click on that. So and that way other team members can see if there's any changes. If there's a +2 moderate pitting, indentation subsides rapidly. And then, of course, a 3+ or +4+. Now, this one, of course, and I'll show you an image. I think that the image on the next slide actually tells you that it is pretty severe, but it's very deep pitting. And the indentation lasts a long time. In other words, once you press into that edematous tissue, it stays like that for quite a while. It just don't go back to the normal, its normal appearance, if you will. And the legs, it looks grossly swollen and also distorted because that tissue, the liquid part of the blood has moved from the vascular space into the interstitial space, and it can really cause the leg to look distorted. We also have this, the scale is going to be subjective as well as qualitative. So we're going to look at that. We're going to do with the tape measure an ankle circumference, which is more reliable. We're taking the tape and we're going around the entire circumference of the ankle, and that would tell us how edematous the patient is. But of course, check with your institution to determine a consistently used scale. All right. And then we perform a standing assessment, and of course, we note any abnormalities of the venous system. You know, for example, varicose veins, if you will. All right. Now, normally, when you're assessing for pitting edema, your fingers should leave no indentation. That would be the normal part of that. Although a pit commonly, the pitting appearance, it's commonly seen if a person has been standing all day or if they're pregnant. So it doesn't necessarily mean that they have any cardiac or circulatory issues. It might be that, again, the patient is pregnant or you're standing all day. You know, that blood, it kind of stagnates a bit in the lower limbs. It's not moving as effectively up towards the heart like it is supposed to. All right. There might be bilateral dependent pitting edema that you, in other words, in both lower limbs. And so when we talk about dependent pitting, when the limbs are when you're standing, your limbs are dependent, right? That's what we refer to as dependent. You're standing, and so the limbs are lower than the body and whatnot. And you can see this pitting edema in certain conditions. You might see it in heart failure, all right, because blood is backing up from the left side of the heart to the right side of the heart and back into the venous system, and can go down into the lower limbs, right? And then that fluids seep into the interstitial space. So you will see that in your heart failure patients. Also, diabetic neuropathy, you might see it in those patients, as well as hepatic cirrhosis. The liver produces this protein called albumin, and it is that albumin that keeps the liquid part of the blood within the vascular space. All right. And as long as you have that albumin in the vascular space, it creates a kind of pressure that keeps the liquid part of the blood in your blood vessels. If someone has cirrhosis of the liver is not able to produce, the albumin, and therefore the liquid part of the blood begins to seep into your interstitial tissue, and you would note edema in those patients, or pitting edema in those patients. That kind of gives you an idea. This is something you'll hear about again, especially MedSearch 1 and 2, and especially Adult Health 3 or Complex. All right. Take also a look at figure 21.20, and I think it's designated B. Actually, let's see. 21. Yeah, so this is what it looks like, right? So once you depress the patient's skin, those indentations will look like this, right? And then if it's normal, well, of course it wouldn't look like that, but we determine the severity of the pitting edema depending on how long this stays. All right. And then this is what it should go back to. But again, it takes some time. This is what we call pitting edema. Right. And this is how we check pretibial edema. Take a look at that. This is the tibia. And we check for edema here as well. All right. It says normally your finger should leave no indentation, although pit commonly is seen if the person has been standing all day or is pregnant. So you got to keep that in mind as well. Things to consider. Check this out. This is really important. If someone has unilateral edema, this usually occurs with the occlusion of a deep vein. So someone may have a DVT. All right. Unilateral or bilateral edema occurs with lymphatic obstruction. Sometimes the lymphatic system of blood vessels are obstructed. And with these factors, it is brawny, the color, if you will, or non-pitting, and feel hard to touch. So you won't see the pitting edema if it's a lymphatic obstruction, like you would see in the arterial space or system. All right. Let's see. All right, so now we want to look at our color changes. This information can be found on page 515 to 16 for the physical examination demonstration. If you suspect an arterial deficit, We want to raise the legs about 12 inches off the table and ask the person to wag the feet for 30 seconds to drain off the venous blood. This will help to drain off the venous blood. The skin color would now reflect only contribution of the arterial blood. In other words, the arterial blood is, it will be, we'll know what um, the limb should look like if, see, I'm trying to explain this in a way you all can understand it. Basically, you're draining off the venous system so that we can see what is happening with the arterial system. All right, so that's why we're doing that. And that's why it says here, skin color now reflects only contribution of arterial blood. It will have nothing to do with the venous, but more of arterial perfusion. Guess that's better to put it that way. Of course, we have to be aware of ethnic variations. I mean, people of color, it may be a little more difficult to determine skin color in those of color versus Caucasians. Now we should have the patient sit up with the legs over the side of the table. And then we compare the color of both feet, that bilateral comparison, and note time it takes for the color to return to the feet, right? And this should normally take about 10 seconds or less. And we also note the time it takes for superficial veins around the feet to fill. So we're looking at the blood vessels of the feet and seeing when those blood vessels will pop out again. They're not flat, but they're popping out. And so that'll also tell us about the superficial veins. And then test the lower legs for strength and sensation. All right. And so even though we're dealing with the peripheral vascular system, this will help us to determine the musculoskeletal and neurological assessment as well. So remember I was telling you all, you have to try to assess as many systems as possible, while the patient is in a certain position. You don't want to keep putting them through all these different moves, positions and what have you, especially if they're elderly. All right. Right. Now, this device that I was talking about, the Doppler ultrasonic probe. Right. So I mentioned that we use this device to detect weak peripheral pulse to measure a low pressure or blood pressure in the lower limbs. Right. Now, the Doppler probe, it actually is able to magnify the pulses, those pulse sounds from the heart and the blood vessels, because that's what's actually making the sound. It is the heart pumping, and this is how we get a pulse is generated. All right. Now, we position the person supine with the legs externally rotated so that you can reach the medial ankles easily. All right, because this is where you're going to place the end of that probe on those different landmarks in order to try to detect a pulse. All right. Now, we don't just place the probe on top of the skin, right? In order to detect the pulse, we have to place some gel in those areas, right? Place some gel in those areas. It's some kind of like ultrasonic gel or something. I think sometimes in the hospital we would use what is it? Not Vaseline. Uh, um, it's a sterile kind of gel, but I'm kind of blocking. But we would use that as well in the hospital. There is like a white container with like blue writing that we would use the gel in that system, but there's like some sterile, it's really slippery, but we would use that to we place it over the area where we determine the pulse is, and then, or in the general area, and then we can take the Doppler and just kind of move it around until we actually hear a pulse. So anyway, so we place a drop of coupling gel on the end of the handheld transducer. We usually put it on the scan, to be honest, right? We place the transducer over the pulse site, wherever you think the pulse site is, and then you kind of move the device around that area, all right, at a 90-degree angle. And what is very important is that you do not apply hard pressure, because then you will obliterate your pulse and you won't be able to feel the pulse. And so it has to be light compression, and then locate the pulse site by, you hear this swooshing, swashing sound. All right, it's kind of hard for me to make that sound, but I don't think that would be too cute. But anyway, you can always YouTube that, and you can hear what that would sound like. I don't know if we have this device in the lab, but I guess we'll find out. Maybe you all can tell me if this device exists. Right. Make sure you take a look at page 516 and 517 for this information. All right. Now, this is the ankle brachial index, or ABI. I think when I spoke with Dr. Mitchell, she said that this is something that you all won't be practicing in the lab, but it is important for you to know, because basically with this device, we're trying to determine arterial blood flow, and that there's some math that will be involved. I won't make you all go, at least I don't think, she requires that you all go through that, but we'll look at some of the math so that you'll see exactly how they come up with some of the numbers. And then, of course, you look at this range that will tell you the severity of the arterial insufficiency. All right. But with this device, you're using the Doppler stethoscope. This is a highly specific, but it is non-invasive, which makes it a great device to use. And of course, it's readily available to determine the extent of peripheral vascular disease. All right. Now, specific criteria for this procedure will be with the patient lying flat, and heels will be fully supported, along with the correct choice of a cuff size. Because with this device, not only are we going to use a Doppler stethoscope, but we need a blood pressure cuff as well. I'll probably show you guys a video in class, or you can also look this up as well, but I try to show one in class and how this procedure is performed. It's not a difficult procedure at all. All right. Now, part of the criteria also is that the patient cannot smoke within 2 hours, with 5 to 10 minute rest period before the actual measurement. Now, 2 measurements are taken, and then the average is used as the recorded pressure. And so let me see if I can show you what the formula looks like. Ankle brachial. Those are some rough looking toes there, isn't it? Anyway, all right. So this is the Doppler device that I was telling you guys about. All right, because sometimes, again, you cannot palpate the pulses because they're so weak, and so this device helps us to do that. This is that gel I was telling you about. Sometimes we have that, but then other times we get this. It's a sterile kind of a gel that we have in our nursing carts and whatnot. If you can't find this, now this is that ankle brachial index. So this is what is happening. So see what it says here, calculate both ABI using this formula. So if we're looking at the right lower limb, so we take the highest right ankle pressure, And of course, then we take the highest arm pressure, and that can be, of course, the right or the left, right? So as you use this device, you'll be able to determine as you you squeeze the bulb on the cuff, and you detect that first sound, of course, which will become when you're doing the ankle, of course, you get a systolic pressure of, let's say, 132. And then you take the one in the arm, and then of course that would be a 124. Say if you're using your Doppler and you detect that when you get that sound, you hear it at the 124 a number, and of course the same thing here. But now take a look at this again. You see where it says 1.06 or 106%? This indicates that there's no flow reduction. All right. Um, and so basically what that means is there's no reduction in flow because of that value. But this is the kind of the legend that you will be looking at. Let's say if that number you take is showing between 0.91 and 1. This will be considered borderline cardiovascular risk, right? Now, in ABI, 0.90 or less indicates PAD. If it's between these two values, it's mild PAD. If it's between these two values, 0.70 and 0.41, it's going to be moderate. If you get a value of 0.40 to 0.30, this patient has severe PAD, usually with rest pain, except in the presence of diabetic neuropathy. All right. And of course, if it's less than the 0.30, the patient has ischemia with impending loss of tissue. In other words, the patient may lose the extremity. All right. That's pretty low. That's almost like almost no blood flow to the limb. So just take a look at this information here. It just gives you an idea of how to get the information. The PT, of course, is like the right posterior tibial. You can take your probe, and you can use the dorsalis pedis and also the posterior tibial pulse. You can do either one. And again here, the right or left arm. All right, and you get those values. And here, same thing. You'll of course get the left leg, and then you'll compare that, or rather take the value of the pressures in the arm, and whatever that is, just like this formula here, you'll do your math. So like 124 divided into 132, and this is what it comes out to be. This is what you want to see, of course. So that gives you an idea how that works, I hope. All right. Let's see. Go back here. All right, so this is the Wells score for deep vein thrombosis, or DVT, a blood clot. And so there's a combination of assessment findings that are categorized in low, moderate, or high probability of a DVT. It's just a tool that we are able to use. I don't think I've ever used this particular tool, but it's a tool that we actually use to determine this patient risk of developing a DVT. Right. Now, the clinical model includes 10 categories, focusing on it can be due to malignancy, mobility limitations. You have some patients who are not up and about, swelling, all right, non-varicose veins, also a previous history of DVT, alternative medical diagnosis, at least as likely as a DVT. All right, and this is something I don't think I didn't see this on your test. So, but we still want to be familiar with this, just in case your institution uses it. The higher the score, the greater the risk, of course, here. And so a 0 or less indicates low probability, all the way to a score of 3 points or greater would indicate a high probability. And this would let us know that there's some things that we probably need to do. For example, let's say if it's due to mobility limitations, right? If it's due to mobility limitations here, there's some measures that you can put in place. You may put SEDs on the patient's lower limbs, and also the leg pumps or squeezers, and also place the patient on an anticoagulant such as Lovenox or perhaps heparin sub-Q. So there are things that we might be able to do to avert a DVT from occurring in our patients. All right. And the same with, for example, with the previous history of a DVT. If we know a patient had it one time, we know the patient can have one again. All right. And so we employ measures to prevent that. Again, leg squeezers, SEDs, those are the leg squeezers. So SEDs, TED hosts, prophylactic, um, you know, anticoagulants such as your, again, Lovenox and your heparin. And there are some other products as well that can be considered, but those are mostly the ones that are used. This information can be found on page 517 and 18 of the physical exam demonstration as well. All right, now this is developmental competence regarding infants and children. When I taught this class years ago, I'll be honest, I really didn't spend a whole lot of time on infants and children because I felt like you guys would get that in pediatrics and what have you. But according to Dr. Mitchell, and I believe I spoke to another faculty, they said that they did speak about, uh, infants and children as well. So I think it's still important for us to review the material. And I will let you know if I provide you all with a focus sheet if you have to focus on some of these areas. All right. So again, we're dealing with infants and children. Now, pulses or pulse force should be normal and symmetric in both the upper and lower limbs, just like with adults. They should be similar. Right. There's also palpable lymph nodes that will be seen in your healthy infants and children as well. The lymph nodes should be small. They should be firm, or what we call shoddy. All right. These descriptions are very important because you could be asked on a test what would constitute normal lymph nodes, right? Upon palpation, of course. They should be movable and also non-tender. If you ever find any patients with a tender lymph nodes, it's probably an infection. Now, keep in mind that if you are assessing these children and they had just had a vaccination will generate or stimulate an immune response. And of course, they can have tender lymph nodes, for example. And so that can kind of skew your results. But of course, you always want to ask the parent, was your child vaccinated? And if they say so, then you can consider that to be a reason why. Right. Now, we have to note the characteristics of any palpable lymph nodes, if you can feel them, and whether they are local, or generalized. Is it just under the armpit, or or is it more widespread throughout the body? That would be important as well. All right, and that is on page 518, so take a look at that. Let's see, the pregnant. I think I'm getting towards the end of this. And then you have your developmental competence and pregnant women and also aging. And of course, in the acute care setting, you will see mostly the patient population that we tend to care for is the aged, those 60 and older and what have you. So So very important to know what their assessment findings would look like. So pregnant women, we can expect diffuse bilateral pitting edema in the lower limbs, especially at the end of the day when they've been walking around and their legs are in a dependent position. And so we will note that they will have some pitting edema. And it doesn't necessarily mean that it's cardiac related or any other pathological condition. Right. Now, third trimester common findings, and of course, this can be helpful for those of you who have a desire to work in maternity. But there is a peripheral pitting edema and also varicose veins you'll find in these patients. Now, as far as your older adults, the dorsalis pedis and the posterior tibial pulses, you may not be able to find them as well. And so the Doppler device would be warranted in those cases. Because they're elderly, the veins have changed, the arteries have changed, there's more plaque buildup in the arteries. And so you're likely are not going to be able to feel their pulses like you would in someone who is normal, who don't have those age-related structural changes. You may also note trophic changes associated with arterial insufficiency. And what this looks like when you think about trophic changes, the skin would be thin and shiny. Then when you look at the nails, like the nails I showed you in the book a moment ago, they would be thick and ridged. And also there would be loss of hair on the lower limbs because there is not as great a blood flow to the lower limbs. You know, these patients have cardiac issues, they have vascular issues, and so they are getting some blood flow, but just not enough. And so you'll see these changes. Although these changes are not considered, these changes would not necessarily be considered sometimes pathological. It could just be more to do with the fact that, you know, you have an older population that experiences these types of issues. All right. And it's not like we would probably do a whole lot other than maybe, you know, I suppose there's some medications they can place these patients on, maybe an aspirin, maybe talking to them about exercising and, you know, those types of things. So this information is on page 518. All right. Now, let me say this to you guys. So on your NCLEX, and you should always be thinking about NCLEX. Everything you do in these courses should be working towards NCLEX. Not so much as working to get out of a course, but working towards your NCLEX, all right? You'll have a much better outcome. But health promotion and maintenance is a fairly large component of NCLEX. And so you have to know about, in particular, your disease processes and you know, all the other related information that you have received since you've been in this program, because we need to really move more towards a health promotion and maintenance type of healthcare in order to keep people healthy, because that's more cost effective. But and so state boards recognize that, of course, and you have to make sure that you understand these disease states, if you will, so that you can teach these things to your patients and keep them healthy. All right. Let's see. So as far as health promotion and teaching points, we're focusing on foot care. So we correlate with significant, excuse me, we correlate with significant comorbidities as well as age-related aspects. There's some comorbidities like diabetes that will bring about some abnormal findings, but then there are age-related issues that it's just age, you know. The skin is not supposed to sag, but of course, or wrinkle, right? Not when you're young, but when you're old, you will see that, but it's more age-related. It's not an abnormality. It's not a pathology that needs to be worked up. So just kind of keep that in mind. Inspection to identify for possible abnormalities and skin breakdown. So we're inspecting the skin for abnormalities, and we have to know, again, what is normal for the aged, what is normal for those who are young, right? Maintain exercise to improve circulation, and pay attention to seated positions during the day. Um, so we're teaching patients about the importance of exercise. That might be passive exercise as well, certainly active as if the patient is able to do so. And when it talks about attention to seated positions during the day, sometimes we place these patients in a chair and we leave them there all day, and we don't have them shifting their weight, around and ensuring that they're not putting pressure continuously in that one area. All right. So it's really important that we're doing these micro kind of turns, if you will, maybe putting a little pillow on the right and then switching to the left, tell the patient to move around as much as possible, if it is possible. So just think about those kinds of things. Wear comfortable shoes that fit well and wear shoes outside to prevent potential injury. And this is especially true with our diabetic patients. They have neuropathy, they can't feel their lower, there's this numbness thing going on, and it can be very severe. They can walk outside, walk on a piece of glass, a nail, or what have you, and that glass or nail can be in that foot for a long time before they even notice it. Now, severe infection has come about, and gangrene has now set in. You can't get the infection under control, and now the patient loses their lower limbs. And so you must tell them to wear shoes at all times. Tell you the truth, even around the house, because you know how it is when you live in a house with other people, even just by yourself, you don't know what you may drop on the floor, right? And so they have to be able to inspect their feet daily to make sure that there is no nail or glass or anything like that. So all a part of the health promotion modalities. And then lubricate the skin on your feet to keep them hydrated. You don't put lubrication between the toes, right? Because you don't want the skin to break down, but you put it around the toes and, of course, on the skin of your feet, toes, and so forth. Just not in between the toes, because you don't want the skin drying and then cracking. And now that first line of defense you have now it's been compromised. And so that can set a patient up for infection. And of course, well, all to keep the lower limbs, our skin hydrated. That's what I'll say about that. Now, these are some of what we refer to as, of course, abnormal findings, variations in our pulse contours, ways in which we describe our pulses, all right? And what I would have you to do is make sure you take a look at your textbook. If there anything that you need to know here, I'll let you know as far as your quizzes and exams. But these are just ways we describe what our findings are. All right. For example, when we look at a pulse, is it weak and thready? A weak and thready pulse, which would be a 1 plus. Of course, the other extreme would be full and bounding pulse. For example, if someone is fluid overloaded. If you're fluid overloaded, then or a fluid volume excess, you have too much volume, right? As in heart failure, or as in getting too much IV fluids, then the pulses will be more bounding, right? Um, and some of these other terms I have not reviewed for a minute. Oh, no, that's not what I wanted. Let's see. I'm just kind of curious. I want to see if I can find some of these terms. And all this information is really important. Check out here. Finally, keep the skin on your feet soft and smooth. Use mild soap and mild skin lotion. Avoid adding oils bubble bath to the bath, it makes the feet and tub very slippery, and of course they can fall. Where are those other terms? Yeah, here, the variations in pulse contour. So take a look at the this description, weak thready pulse. We would describe that as a +1. That would be what you choose as a drop down. Hard to palpate. You need to search for it. It may fade in and out and easily obliterated by pressure, meaning you put too much pressure on it, it'll disappear. What does that mean? It's associated with decreased cardiac output. There might be peripheral arterial disease, an aortic valve, stenosis. You know, the aortic valve is stenosed. You barely get blood through that opening. And take a look at the full bounding pulses. We saw this earlier, actually, but easily palpable, pounds under your fingertips. You can feel it pounding, right? Those hyperkinetic states, those states that causes these pulses to really increase, exercise, anxiety, fever, anemia, as well as hyperthyroidism. Check out this one, greater than normal force, then collapse suddenly. This can be an aortic valve regurgitation, patent ductus arteriosus. So things like this, I'll let you know if you have this, and that way you can focus on these terms. All right. Yeah. All right. Good to go. And of course, these, already have these definitions. So the definitions are on page 522. Just take a scan, kind of look at the information until I get back with you. All right. We're getting to the end, folks. Getting to the end. All right, and these are abnormal findings for peripheral vascular disease. These are some of the disorders that you will see when blood flow is compromised. All right. Now, this is quite, I actually provided you some notes in the system. It's under my notes in the PowerPoints, and so I want you to take a look at it. But this information is in table 21.2, starting on page 522. All right. We look at the arms and the lower limbs. You might see conditions in the arms, such as Raynaud phenomenon, lymphedema. Also, as far as leg ulcers, it can be of the arterial, venous, or diabetic type of ulcers. And here you have the arterial or ischemic ulcer. You also may have the venous stasis ulcer and the neuropathic ulcer, right? Such as in diabetes, you're not getting enough blood flow, and of course, you know, it does affect the nerves. And then you have your peripheral vascular disease in the lower limbs, where you have the superficial varicose veins, deep vein thrombosis, and then you have your peripheral artery disease, which is different from your venous type. You have the aneurysms and also occlusions. Now, what I want you to do with this, let's see, let me see. All right. So in your book, it is going to give you essentially a description. For example, arterial, talked about here. You know, actually, let me see. Yeah, let me do the first one. So as far as the arms are concerned, there's a condition called Raynaud phenomenon. All right. And I want you to look at that description. It says, it talks about episodes of abrupt, progressive, tricolor. All right, you'll see like 3 different colors. Change of the fingers in response to cold, vibration, all right, and also stress. So in other words, you'll see these changes in color if any of these elements exist, cold, vibration, or stress. So you will see a white color or pallor in the top. Let's see, I think there's actually a, let me go back in your book. That's not what I want. See if your book tells you. All right, so take a look at, I don't think it will show it all that well. Let me see if there's a figure. I guess not. So I guess I can enlarge that. There you go. All right, so take a look at that. So so you have the white pallor in the top figure here from the sympathetic, basically the sympathetic nervous system. All right, we refer to it as sympathetic mediated vasoconstriction. I'm not sure if they talk to you all about the sympathetic nervous system, the parasympathetic nervous system, but just so as not to go deeply into that, the sympathetic nervous system causes blood vessels to constrict, and the parasympathetic nervous system is the opposite. So just kind of think about that. And so with this condition, apparently the sympathetic nervous system is at play here. And when this sympathetic nervous system kicks in, causes vasoconstriction, and this results in a deficit, or it decreases the supply of blood to this part of the hand. So the blood vessels of the arteries are constricting, right? And so you can't get enough blood flow in there, right? So it results in a deficit in supply. There's another color that you will see here, and it's called what is blue, or cyanosis. And you'll see that in the lower figure from, I don't know if that's supposed to be a figure or fingers, but anyway, so the reason you will see the cyanosis is because it comes from a slight relaxation of the spasms. See, the blood vessels are going through these spasms, but during the times when the spasms relax a little more, it allows a slow trickle of blood through the capillaries and increase oxygen extraction of the hemoglobin. All right. So basically, you got a little blood going in, but just not enough. That's what we're essentially saying. And you get a little bit of oxygen to the area. So you have that cyanosis again from spasms. It's constricting, it's dilating. During the dilation part of it, you get a little blood flow. All right. And so, but not enough, and so you will see some cyanosis. And then one of the other colors is rubor, or red. And you'll find this in the heel of the hand, which is caused by the return of blood into those dilated capillary bed, or also what we call reactive hyperemia. In other words, just a large amount of blood flow back into the extremity. And so then you get that characteristic red color. So you see that red, white, and blue color. And I don't think you have to really know some of these technical pieces that I just described to you, but just knowing that you'll see a characteristic red, white, and blue color, you may have to more or less identify if it's, for example, Raynaud's phenomenon versus some other disorder. And so that's what's more important. All right. Now, what is also important about this particular condition, the patient may have a cold or numbness or pain along with the pallor and the cyanotic stage. So you may see those characteristic signs and symptoms. There may also be burning. All right. You know, those nerves are being, they're not getting good blood supply, so they're mad, they're angry, right? There may be throbbing pain. There's also swelling along with rubor, or the red looking color of the hand. So here, what is important is, well, not only the signs and symptoms, those are always important, and get used to understanding what the symptoms are for any disease process, because you'll see this with your medical surgical med-surg 1, 2, as well as complex. All right. Now, what is also important is the therapy. What do we do? All right. So we want to avoid the cold, and that is one of the most effective therapies. Now, when these episodes, the Raynaud's phenomenon episodes do occur, we want to rewarm the hands by putting on some gloves. Uh, we also can rub our hands in warm water. That would cause more vasodilation of the blood vessels, because heat causes blood vessels to dilate, and the reverse, of course, cold causes blood vessels to constrict. Obviously, we do not want vasoconstriction. We want vasodilation, and the heat will do that. Or we can use chemical rewarmers as well. Now, after rewarming, a typical attack can last from 15 to 20 minutes. It is important, of course, this is the health promotion piece, to avoid smoking, or to instruct patients to avoid smoking, because smoking causes vasoconstriction. There's also sympathomimetic drugs. They're drugs that stimulates the sympathetic nervous system that these patients may need to avoid, because if they don't avoid them, you get that vasoconstriction effect. Certain drugs for migraine headaches, and also attention deficit hyperactivity disorder type of drugs will have to be withheld as well, because they can lead to this or exacerbations of this attack, or bring about this attack. All right. So you'll see this the description. Well, this is the description that I just talked to you about, and for Raynaud phenomenon, and then you'll see some of the signs and symptoms along with some of the interventions. And so that's how I want you to look at this information. There's quite a few here. There's Raynaud phenomenon. There's lymphedema. You see this especially if someone has breast surgery. So that would be your peripheral vascular disease in the arms, but you also have pain in the, let's see, is that the same thing? Yeah, and then you have your leg ulcer, which is the arterial, venous, and diabetic type of ulcers. So I want you to take a look at that, right? Take a look at the information here. It gives you a description of this condition. It actually tells you what well, it gives you the general description here, but it tells you what the subjective information would look like as far as what the patient is describing, pain mostly. And then you have the objective findings, all right? And so this is what you will be able to observe in these patients. This tells you where you might see these ulcers. And then, of course, well, yeah, so that's everything on this side, because then when you get into like your venous stasis ulcers, it's the same thing. You want to know what the subjective findings would look like. You want to know what the objective findings would look like as well. You got your neuropathic ulcer, all right? Diabetes hastens changes described with arterial ischemic ulcer, and with generalized dysfunction in all arterial areas. That could be the peripheral, the coronary, cerebral, retinal, and also renal. And this is what I was telling you about, the effect that high blood glucose levels have on the blood vessels, especially the arteries. And when it destroys the arteries to a certain extent, then these arteries that supplies the different organs and tissues will become compromised, and then you start seeing the different problems, of course, in these patients. Now, I won't read through all of these, that I just went over. As far as what I mean by that is, I want you to take a look at the lymphedema and then come down here and take a look at the leg ulcers and its corresponding descriptions, knowing your subjective, objective data. This one here, the neuropathic ulcer. And then I think this is another one. Let me see. Yeah, you have your, let's see. Yeah, and make sure you take a look at, yeah, your superficial varicose veins as well as your DVTs. This is going to be very important, especially your DVTs, because you see that quite a bit. So take a look at that. I will be sending you guys some instructions on how you can access the book and see the things that I have highlighted. Take a look at DVTs here for a moment. It is a deep vein, or a deep vein is occluded by a thrombus, right? So the plaque becomes unstable, and it begins to bleed, and then platelets are going to migrate to that area where that plaque is located and try to stop the bleeding. This is how all happening within the vascular system, right? And so that the platelets, when they become sticky and they stick together, they actually can block off. Let me see if I can show you this real quickly. Oh boy. Nice. Hopefully you'll be able, you can see what I'm doing here. But let's say, for example, so say if this is a blood vessel, right? And so you have, I'll do it with different colors. You have this plaque buildup, right, within the arterial system. This green represents plaque. And so what happens is the plaque becomes unstable, right? Becomes unstable and it begins to bleed in this area. And so then your platelets, that's make platelets, these little red dots. Platelets usually travel around in the blood stream as individuals, but then when there's an injury in the body somewhere, they travel to the site of injury, which is here. This is that plaque that has become unstable. Platelets, they travel there and they stick together in order to stop the bleeding. But the unfortunate part is it causes an occlusion of this area. All right, and that's what can give patients a clot, if you will, from the stickiness of the blood vessels. Anyway, so you have this what we call this. Well, let me kind of back up. So a deep vein is occluded by a thrombus, and this, of course, will cause inflammation and a block venous return. So the blood vessel in the or below the occlusion cannot return to the heart because you have that occlusion, and it will result in cyanosis because you're not getting good blood flow to the area, and also edema. All right. There's a condition where there's a term that we call Virchow triad. It's the classic three factors that promote thrombogenesis. You have stasis, in other words, blood is not moving smoothly. You have hypercoagulability, in other words, the blood abnormally coagulates, forms clots. And you also have endothelial dysfunction. And so that's basically the inner lining of the blood vessel, the intima, and how there's dysfunction there. The plaque especially can become unstable, or there can also be an injury to the inner lining of the blood vessel. Now look at some of the causes. Prolonged bed rest. There can be a history of varicose veins. There's trauma, infection, a cancer, obesity, immobility, heart failure, and also use of estrogen hormones, such as like your your birth control pills. Requires emergency referral because of high risk for pulmonary embolism. In other words, the blood clot that I demonstrated can break off and travel to your heart, to your brain, to your lungs, and so forth. So that's why they're so dangerous. Note that upper extremity DVT is increasingly common as a result of frequent use of invasive lines, such as a central venous catheter. So we're seeing this more because a lot of our patients, they're getting these lines, these IV access devices, and it can affect blood flow. All right, and so you have to, during your assessment, you have to assess these sites and make sure that you don't see the edematous cyanotic or the inflammatory issues in these patients. Check out the subjective sudden onset of intense, sharp, deep muscle pain. Right, that's coming from the patient. But now this is what you're observing: increased warmth. You're touching the lower limbs with the back of your hand. Swelling. So to compare swelling, observe usual shoe size as in the above photo. So may not be able to put on their shoes, all right, shoes that they can normally wear. Redness, dependent cyanosis is mild or maybe absent, tended to palpate, all right? And of course, we can apply this Wells criteria that we talked about earlier. I don't know if they're actually doing this, but you know, I guess I can find out when we go to the hospital. And so anyway, so make sure you check out the rest of these disease processes or conditions here. Take a look at the your textbook and look at that. Otherwise, this lecture would be a whole lot longer than what it is now. And it all has to make sense to you. You guys have to get in the habit of comprehending this information as opposed to trying to memorize the information. Some things, yes, we do memorize, but we want to do more comprehension than memorization because that's a lot of work to memorize. All right. Right, that's 37. Now, there was a chart that I noted that I'm gonna direct you to. So take a look at table 21.2 on page 522. We're still looking at peripheral vascular disease in the arms. Oh no, actually, no, I did that one. Sorry. I'm on slide 38. All right, I was in the wrong place. So let me show you this slide. What we're looking at as far as pain profiles of peripheral vascular disease, arterial disease causes symptoms of oxygen deficit. Remember, because the arteries is what delivers oxygen to our vital organs and tissues. Venous disease, remember the venous system carries deoxygenated or waste products. So venous disease causes symptoms of metabolic waste buildup. All right. Arteries carry oxygen, and the venous system, the veins carry metabolic waste. And so let's go back and look at what that would look like, see what that would look like. And so that is here. All right. So you have arterial disease causes symptoms and signs of oxygen deficit. All right. So you have location, you have deep muscle pain, usually in the calf, because it's more distal from the heart, but maybe lower leg or dorsum of the foot. All right. And of course, it varies the distal to occlusion. So anything below the occlusion and may involve the entire leg. Look at some of the characteristics: intermittent claudication. It feels like a cramp, numbness or tingling, and feelings of cold. And of course, the acute symptoms will be throbbing. And so just take a look at this information. Some of the aggravating factors here, activity, such as walking and stairs. They also have what we call claudication distance. And this is a specific number of blocks or stairs it takes to produce pain. So in other words, you walk, for example, here, you walk 2 blocks, and that's when the pain comes on. Or you walk a certain amount level of stairs, 1 flight of stairs brings on the pain. This is important information for the patient to tell us. So how many stairs it takes to produce the pain. Elevation, and so rest pain indicates severe involvement. So usually activity will cause pain because our tissues need more blood flow as we are active. But then when we are at rest, it requires less blood flow, still blood flow, but just less. And if you're still getting pain with less activity, then you know this disease or this condition has worsened, right? You know, it will be much more worse. And so just take a look at the arterial disease cause symptoms and signs of oxygen deficits, and also the other one here, venous disease cause symptoms and signs of metabolic waste. All right. Let's see, aggravating factors. This is what aggravates it: prolonged standing and sitting. Pain may increase with palpation. So when you're examining them, you know, it may bring on the pain even more. Aching, tiredness, feeling of fullness, moderate to intense, a sharp, deep muscle, tender to touch. And so these are some of the acute symptoms that you might see in these patients. All right. So make sure you take a look at this chart here, or this table, if you will. Yeah, so as I've noted here, it tells you about the location, the characteristic, the onset and duration, and just refer back to that table. We want to know about the aggravating factors and relieving factors, and also the risk factors. What population does it actually impact? And of course, this is a checklist for you, which you can see on page 523. A summary checklist, peripheral vascular system and the lymphatic system. We're inspecting the arms for color, size, or lesions. We talked about that. And you know, this is a guide for you all. It tells you that when you are assessing these patients, what are you looking for? You know, so it doesn't leave you in the dark, if you will. We're palpating pulses, the radial and brachial pulses. We're checking lymph nodes, trochlear node. We're inspecting the legs for color, size, any lesions, any trophic skin changes, you know, the thin, shiny skin, a decrease in hair distribution, and so forth. We're also palpating the temperature of the leg, of the feet and legs. And of course, we use the back of the hand because it's more sensitive to temperature changes. We also palpate the inguinal nodes. We're palpating pulses in terms of the femoral, popliteal, posterior tibial or PT, or the DP or dorsal pedis. And then also we use the monofilament to check for sensory function, the sole of the foot. And so that would tell us if there's some circulatory issues as well, and neurological damage or changes. All right. So that is about it. That's about it. So we're at 2 hours and 4 minutes. And so, again, hopefully I will be able to get to a slide, get through slide 18, and then the rest of this you can pick up, you know, in this presentation, which I hope you find helpful. Sometimes I get a little nervous because of time, and I don't want it to be as long as it is. And so what I would recommend is that you don't have to sit down and listen to this for a whole 2 hours and 5 minutes or however long it is once I end this. But, maybe 30 minutes here or 20 minutes here, 20 minutes there, until you listen to the whole thing. All right. So that's how you do that. But you really need to make sure you have your textbooks with you and take a look at this information because it will help you. Anyway, so I appreciate your attention to this, and I'm going to end this presentation. Thanks, everyone.